So rather than showing some slides, I might skip because of the time. So I have no disclosures except that all these complications are not mine, okay? So they're also a conundrum of complications. So common complications are stroke, valve embolization, annular rupture, coronary obstruction, paravalvular leaks, vascular complications, and others. So what we can do to prevent them is actually appropriate selection of patients and screening, look at the CT scan, analyze the entire chest, the aorta, the subclavians, the carotids, and also look at the descending aorta, calcification, and just not the iliac arteries, and looking whether I can push a catheter or not. So the tortuosity of the vessels is very important. And techniques of developing, even if you have not done it prior to this TAVR, you need to now relearn how to do ultrasound-guided sticks with a micropuncture needle, and the pacemaker should be in a good position, or now actually get rid of the pacemaker and pacing on the wire is also a possibility that I started using it a little bit more, just because pacemaker lead has caused more complications as well. And appropriate size valve and crossover balloon occlusive technique or ipsilateral balloon occlusive techniques in complex patients, and always be friends with the CT surgeons and vascular surgeons. I'll skip these slides because, as we know, the complications are obviously coming down, but still, Sushil presented this paper of S3 5-year data in low-risk patients, low-risk SAVR versus TAVR. The pacemaker rates are 16%, even in the lowest risk with the sapien valve. So it's not low, as we always think. So let's look at the stroke, okay? So here is a sapien valve in an 81-year-old woman. I'll just ask you to pay attention to the the slide on the right. What is happening is that as we're advancing the catheter, we're near close to the valve. I don't think I can show a laser. You can see that there is a little bit of atheroma being advanced. So you are able to see that, right? So we didn't know what to do. We stopped and we thought about it. We said, okay, it's all right. Let's go ahead and push it in still. And it went around, and we finished the TAVR. And so the TAVR was deployed. And then we are pulling back. Actually, it comes back again. The whole thing came back along with it. But it caused occlusion of the femoral artery here. So we dragged atheroma from the descending aorta into the arch and pulled it back, but it definitely caused an atheroma. So then the 30-day stroke. So actually, as we can see this in the slides anywhere, so I'm not going through these, okay? So 2 days later, patient has a severe agitation and MRI is done, and obviously patient now has a stroke, multiple actually strokes. And the patient ultimately died after some time. So emboli protection with Sentinel, we know the Sentinel IDE device actually is very good. It prevents the primary endpoint was not met, but major disabling strokes are lower with Sentinel. So I will leave it up to you how you decide. I think some people say it should be used in 100%. Some people say selected group of patients that you can use Sentinel, and it's up to you. How do you want to? So this is another 86-year-old woman. So for the prevention of that would be, as I said, look at the CT scan. If you have atheroma, choose an alternative site. Even if the vessels are large, if there is a huge amount of atheroma in the descending aorta, now I switch to carotids or other alternate access. So here is an 86-year-old woman. Finally, at that time, the sapien valve was approved for valve-in-valve by the FDA, and we were deploying that. And as you can see in the in the first picture, onto the left, actually, you can see that as it is being deployed. Let me go back and come back. Okay. So the balloon ruptures actually while doing the deployment on the right side. So the BAV was done on the left, and on the right side, suddenly we lose the contrast, and it goes into the ventricle. So the balloon ruptured in this patient, and I don't know whether you remember, Sushil, I called you, I stopped the case, and I called Sushil, I called other people, hey, what do you think I should do in this patient now? And the vascular surgeon was in the room, and we said, just pull it out. We pulled it out, and this is what happens. The entire aorta is scraped down along with the iliac arteries, and there is iliac artery occlusion. patient is hypotensive. The vascular surgeon opened up the abdomen, the chest, and a Coda balloon was used and trying to save this patient. Patient died on the table. She was actually my research nurse's mother. And so what happens when a balloon ruptures is what we don't know is how it ruptured. Is it a linear rupture? If it is a linear tear, nothing will happen. You can pull it back into the sheath. If it is actually a circumferential rupture, like you see on the picture on the right side, that's a very hard balloon. And it's very tough. It's like an umbrella being brought down within scraping the entire aorta. So since we don't know, at least whenever it ruptures nowadays, I tell my friends and all of you again, if you have a rupture, just ask the surgeon to open up the chest, because we are taking a chance on how to maybe do it. Otherwise, you have to cut it, maybe put a large, long sheath, and then you probably might be okay, like a 20 French or 24 French sheath. So then aortic ruptures. The predictors of aortic ruptures are oversizing, eccentricity of the annulus, and calcified valve. So here is a patient that has been oversized in the original sapien valve, more than 20%, and immediately you can see a double shadow in the pericardial space, and patient is hypotensive. There is no doubt this patient has pericardial effusion. Obviously, we are doing on a TEE, so we recognized it. And then the patient had a pericardial tap, and you can balloon it and see if it closes. Otherwise, actually, better to ask the surgeon to open up the chest and fix it. That's what we did on that patient. So the conduction disturbances, again, I think we have now learned about membranous septum, the depth, and we are trying to implant either 80-20 or 90-10, and trying to avoid pacemakers. But as I said in the S3 low-risk study, it is still pacemakers are about 16%. And that is because to get rid of the paravalvular leaks, we've made the skirt, which reduces paravalvular leaks, but it also puts more pressure on the conduction system. So I think we'll skip that moderate paravalvular leak. Coronary obstructions, we'll see a couple of slides on that. Here is a high-risk coronary protection case with the low valve-in-valve and low coronary heights, and we have done even with Dr. Rath, and I did a couple of cases as well, and 6.8 millimeters of left coronary height. That went quite well with the my valve that in a native valve. So, but whenever we do valve-in-valve and low coronary heights, probably better to not do it unless you really have to do it as the only option in these patients. In low-risk patients, probably, or intermediate-risk patients, try to see if a redo surgery can be done. Or if you have to do it, keep a guide liner inside the coronary artery and with the wire. I don't put a stent, but here, as you can see, there's a stent, but you can usually pull back the stent and deploy it. But especially nowadays, I just have a guide liner ready to do that. So when you are in doubt, and if there is any doubt, just stent the left main. Or some people prefer to do chimney stenting, and I don't like chimney stenting that much. So this patient, after stenting the left main, it is resolved. But if you do have coronary obstruction, especially in the self-expandable valves, it is much higher than the balloon expandable valves. And if you're unsuccessful PCI of coronary obstruction, the mortality is 100%. If successful PCI after coronary obstruction, the mortality is 22%. So really, the 30-day mortality is very high. So let me show you a couple of interesting cases. 91-year-old woman with severe aortic stenosis, STS is 6.5. And obviously, multidisciplinary approach, transfemoral TAVR was recommended with the Evolute FX, the 26 millimeter valve, and the Sentinel device as well. So while deploying this, I think I can tell you that actually 80% deployment and the 100% deployment also happened right there, like this. And so the valve embolized. Okay, so maybe a couple of you might say why it embolized. So second valve was also deployed. And so now actually, what do you see? So two things. The number one, the right coronary flow is less, but also there's a dissection here on this side. And so well-seated valve and aortic ascending dissection, and the valve-in-valve obviously embolized, and so there's probably coronary obstruction as well. It looks like there is no AI, but obviously suprasternal images show no evidence of propagation of the aortic dissection. But however, this patient complicated by ischemic stroke, all the complications that you want, coronary obstruction, to ascending aortic dissection, to ischemic stroke, and acute kidney injury, and patient died 8 days later, stopping life support as the family did not want to further cause the problems. Again, another patient, pop-out valve during deployment, and so the second valve is deployed. And so again, 1 hour later, patient develops chest pain and ST elevations. And if you think at it, why it happened, this is what happens. There's completely obstructing the coronary flows. So if you want to ever do a pop-up valve and the second valve inside the pop-out valve, snare and pull it back. But snaring is also important, how you snare. I caused a dissection one time with the snaring the first valve, so be careful. I think, so these are very important to make sure that these small STJs and sinuses are narrow. Be very careful of using a self-expandable valve in such a patient, as the coronary obstructions can happen. So think about not just looking at the annular area or perimeter and saying, this is the valve that I want to. Look at LVOT, look at intercommissural distance in bicuspid, look at a sinotubular junction, look at sinus of Valsalva. All these things have to be on coronary heights, and to see whether there will be coronary obstruction or annular rupture. All these things will be important to understand why and what size valve we should use. So why does valve pop out? There's one thing is not enough calcium. Number two, there's too much tension in the delivery system. There's not, as I showed you in those cases, actually the nose cone was not centralized. And sometimes there may be PVCs and the failure of pacemaker capture and pulling on the delivery system before releasing all the tabs. As you saw in the live case this morning, actually they were very careful. Dr. Ravinder Singh Rao was very careful in making sure the tabs were completely released. So hypotension is a cause that actually can happen at any time of the TAVR, whether it is peripheral arterial perforation, and you need to do an early angiography to diagnose. And a severe mitral regurgitation from the LV wire can get caught in the papillary muscles or be caused by a tamponade. So you can look at an echo and make sure that those are not the cases. And balloon aortic valvuloplasty can cause severe AI tamponade, and you can look at aortogram and echo. And after the valve deployment, severe AR, coronary occlusions, and tamponade, and echo or aortogram and coronary angiogram will give you a clue as to what is the cause. So this is a patient after I was proctoring. I could not finish my sentence in time. I was telling the proctor to please make sure you remove the sheath very slowly, millimeter by millimeter. But before I completed my sentence, he pulled it out, and along with it came out the femoral and iliac artery. And luckily, there was a vascular surgeon that actually did this entire surgery over 2 months, and several skin grafting has to be done, but luckily the patient died. Another patient of mine, the same surgeon removed from the subclavian artery, but the subclavian came out. Along with it, actually, the patient had an IMA, and unfortunately, that patient died on the table, so you can't really save all of them. So in summary, the TAVR complication management is based on patient selection, increased operator experience, and obviously experience comes from bad judgment, and improved device technologies are key to prevent complications. The pre-TAVR imaging, looking at the 3D TEE and CT scan, is most important. And adjunctive techniques help to control and manage catastrophic situations, and if not, call sometimes the other members of your society to get some ideas on how to save that patient from the complication. Accessibility to alternative access site, we prefer right transcarotid in the patients who have even atheroma in the aorta, and heart team with knowledgeable and complementary members is very important to have to manage and prevent complications. Thank you.